Alright. The heart is a muscle. We need it, otherwise we die. And we all want to avoid killing people. It works by electricity moving through it, and the lines that we see on the monitor is a reflection of that electricity. The electrical swiggles that we see tells us what's going on with the patient. If everything's working, then we've got proper functioning. If it's not, then that's what we're here to talk about and figure out what that means for our patient and what is actually going on. Hence the picture on the first slide. Or would be a slide if we'd started off where we were supposed to. SA node, starting at the top, moving all the way through, that would give us normal sinus. Everything else is when it doesn't start. If it doesn't start at the SA node, and goes from somewhere else, is what happens how we get all of our other rhythms. The next page is a breakdown of what we see in a correct normal sinus rhythm. Your P wave, your QRS, and your T, and sometimes your U. Your P is a reflection of the atria, your QRS is your ventricles, and your T and your U is usually going to tell you indications on your electrolyte statuses on your patients. Okay? Your segments, so your intervals, is also going to tell you how well the electricity is moving from one portion of the heart to the other. So when your intervals are prolonged, that means that the electricity isn't moving from one part of the heart to the other at the correct rate. And that also gives us clues that something is going on that shouldn't be. These squares are going to be the same no matter what type of machine you're using, where you're at, whether you're doing a 12 lead, a 3 lead, a beta scope, or what. This means that calipers are nice, but not required. You can figure everything out by looking at your little boxes and measuring things, okay? They're always going to be able to tell you the same thing by figuring out how many little boxes, big boxes, and how much space you've got between everything. Down below is just a list of all of your numerals. Next page. Normal. This is what we want everyone to do. This means that everything works. This is your happy patient. We want everybody to look like this. But if they did, they probably wouldn't be here. Everybody knows Tacky and Brady, so I did not include them in here. So if they're sinus, but it's fast or slow, it's normal, Tack, or Brady. Sinus arrhythmia. You can be irregular and still be in sinus. This is not seen very often in the hospital though, because this is usually your young, healthy people. This is someone who's 30 and runs every day. When they breathe, usually while they're sleeping, they'll go and actually deep breaths will make them sinus irregular. So you don't see them very often here, but you can have an irregular rate and be in sinus. We just don't see it very often here because they're usually very healthy and so they don't want to hang out with us. Sinus blocks. You will just have these pauses. There's different types, but the main thing to understand is that they're normal sinus, and then you lose beats. How long you lose a beat determines what type it is. Sometimes you just drop one, and it's in multiples. Other times it's a longer stretch. If you lose it for 6 seconds, that's when you're starting to have an actual emergency, because then there's no blood going to the brain. Probably want to do something. But it is considered normal for people to drop a beat or two. So there's still going to be a sinus patient when they only drop 1 or 2 beats. Okay. AFib. For some reason, this tends to be the most common irregularity that we see in the hospital. The important thing to remember about this, though, is that you need to have it be irregular and not have P waves. There are going to be times when you have an irregular rate, and there are going to be times when you can't find your P wave. If you don't have both of these things, it's not necessarily going to be AFib. There are other things that look like it that aren't AFib. And the fact that AFib is so common means that other things get mistaken for it very easily. You can have fine or coarse. Be aware that sometimes it just looks like it's flat, and that's why you can't find any waves. A flutter, when you see it, is very, very distinctive. You can't miss it. It's just that perfect sawtooth pattern. Until you see it, you're not really sure, but when you do see it, it's very distinctive. Okay. They'll tell you that it doesn't have P waves, but really what it is that there are so many P waves that you just can't count them anymore. Okay. Accelerated junctional. There are lots of different types of junctional rhythms. I put the accelerated junctional rhythms in here because it gets mistaken for AFib a lot. Because if you look at it, it doesn't have P waves that you can see. The big difference is it has a regular rate. When you look at it, you don't see a P wave, and it does tend to look a lot like a kind of a fine AFib. But with the regular rate, you know that it's got to be something else in there. A regular junctional rhythm will be slower. So if you're looking at something you think it might be a Grady AFib, think about that first. The junctional rhythms, because they tend to start in the heart lower than the AFibs, are actually more concerning than AFib. And so you want to make sure doctor knows about it, because it could be that the patient's actually getting worse. So it would be a change for them. PVCs, we all see PVCs all the time. Once in a while is normal, as long as they're not getting symptomatic. 2 is a couplet, 3 is VTAC. VTAC is fine. You'll see them being referred to as unifocal, multifocal. So if they're the same shape, unifocal, different shapes, multifocal, it just tells you that it's different parts of the heart. When it's different parts of the heart, more things are involved. There's more problems going on, more concerning. It's just a good idea to know what's going on with the patient's heart. PACs. PACs tend to be tricky because when you first look at a strip, when you're looking at it, what you first see at a glance tends to be an irregular rhythm. But when you look at it closer, what you'll realize is it's actually a regular rhythm underneath. The PAC is an early beat, and once you take out that early beat, you'll see that the rest of it is regular. You have one early beat. If you look on this one, it's the 4th beat on this strip, and it happened and it covered up the P wave. The rest of them are regular sinus. But when you look at the whole strip, just at a glance, it makes it look almost like an AFib because you have an irregular from a distance and they don't all have P waves. And so it's easy to mistake it for AFib because AFib is so common in so many of our patients. So it's just another one of those things where you want to be looking carefully at the whole picture on the patient and see what's going on with them so that you don't get one thing for another. SVT, or somebody drank way too much Rockstar. Usually they come in and they're just palpitations, chest pain, it hurts, it's going way too fast, we bring it down, they feel better. As long as the QRS is still thin, then they are doing okay. That is why this is not as concerning as things like BTAC. And it's always been harder for newer people going in because SVT and VT tend to sound so similar, and they both tend to have really high rates. SVT is never as bad because your QRS is still thin. It is not that as much of a big deal. You get it under control, you slow it down, and everything's going to be okay. And it is usually just too much caffeine, too much stress, drug reaction, or somebody who's doing coke in the car before they came in. Get it down, get it under control, everything's better. Whereas BTAC, they're going to have a heart attack. Wide and bizarre is bad. Anytime your QRS is wide and bizarre, somebody is going to die if we don't do something. Torsade point is just another type of BTAC. You fix it with magnesium, which is the big difference, but it's just another example of why the bizarre is bad. Depends on the doctor. They tend to get more excited about these than other ones, but it's still the same thing. BFib. Your heart is not doing anything useful in BFib. It's twitching. No blood is going anywhere. No oxygen is going anywhere. Unless something changes, they're going to be very dead very soon. And then heart blocks. From top to bottom, first degree is your least concerning. It is just that your P is further out, so your electricity is not moving down as efficiently as it should, and so everything is going slower. Your second degrees, you're starting to drop, and you're not getting all of your QRSs are not all moving through, so you're not perfusing as well as you should. By the time you get to third, you're starting to get patients who are severely symptomatic. You're starting to have serious problems here, and if something doesn't happen, this is eventually going to lead to death. Do we have questions? It's the only way I can remember it is from the poem, so yeah. Otherwise, I get all of them mixed up. I can remember first degree, and then after that, it just doesn't stick at all. Okay, so what's the first one? Does everybody agree? Is it regular?
No, it doesn't look regular.
So it's
like one that's a little bit thinner.
yeah, so that's the sinus arrhythmia. So that's what you're going to get.
31.
Yeah, this is that healthy jogger that never comes into the hospital, and they're sleeping, and they've got that slow respiratory rate that if they were actually getting real drugs, you'd be worried about. But deep breaths, and it goes in and out. What about the second one? It's not quite fast enough for SVT. So AFib with RV.